right. Well, look, everybody who's here, thank you so much for coming. You are at MiHIN Bits and Bytes. This is a workshop where you all can connect directly with MiHIN solution designers and managers. I am not a solution designer, but I do have them here, and they're going to back me up, and they're going to answer any of your very specific questions that you may have along the way, and that we can make sure to get to at the end. I am seeing a hand up, Lee. I don't know why your hand is up, but feel free to use the chat. Everybody, if you must speak up immediately because you have a question and a burning desire, this is a safe space for that. So, I mean, I do that all the time, and so you can do that to me. Let me know what you're thinking. We can use the chat. I've got people monitoring, got lots of people helping me out here. So thank you for coming. Next slide, please. As an introduction, you probably know this, but Michigan Health Information Network, MiHIN, is a nonprofit organization that sits between sectors of care. And we are not wholly owned or controlled by any one of those sectors. Instead, we work on behalf of the public interest to make sure that those sectors, that those systems, that those disparate care teams are sharing the information that they need about their patients. When you lose time and you lose critical information, you lose lives. And we're here to make sure that that does not happen. Next slide, please. And we do this at scale. So MiHIN has built a digital infrastructure that sort of sits in between, like we said, levels of care and system levels. And we have around 44,582 care providers with active care relationships working within MiHIN. And I'm going to tell you in a minute what that means. The point here is that it's a lot of information and it's a lot of data. And a good friend of mine said that data was like a starfish. You can cut off a limb and it's just going to keep growing. And we have to make sure that our system can scale to meet that ever growing data. Next slide, please. We are here today to dive into, first thing I should say is that I always start these with the why. I always try and, make sure that I'm speaking to my 4 favorite words, which are so what, who cares? So what, who cares? Who cares about MiHIN's active care relationship? Well, I'm about to make you care. I will start with the why. I will move through to the who. I will get to the how and then to the what. And the how and the what is probably why you're here, but I don't think you can really get to the how or the what without agreeing on the why. So as an overview, the active care relationship service is really the heart behind MiHIN's patient routing system that enables Michigan's electronic healthcare exchange. The goal is cross-organizational unification of patient data, allowing authorized users, those who have a legal active care relationship with a patient, to access that patient's relevant information. I am going to invite our Chief Privacy and Security Officer to run quickly through why ACRS is legally crucial and directly supports the Center for Medicare and Medicaid Services rules for conditions of participation and the patient access rule. Shreya, will you take us through the next 3 slides?
Yeah, that sounds good. So you can actually skip to the next one because I'm going to talk about this slide and the next one kind of combined. Okay, awesome. So ACRS is really going to be important because, as Joanne mentioned, if we know who has kind of legally defined relationship with an individual, we can really make sure that certain information is available to them. But with that being said, it does kind of pay to consider what we mean when we say a legally defined relationship and similar phrases to that, which we do use quite readily. So one term that we use very often in MiHIN is the statement that ACRS is the foundation for all the sharing that we do. And that certainly makes sense from a technical perspective. And I think that our team is kind of going to go into that aspect a little bit later, but it also makes sense from a legal perspective, just due to the nature of the sharing that we do as a health information network. And by that, I mean that almost all the information that's shared through our health information network is supported by the HIPAA privacy rule. And that rule states that information can be shared between healthcare actors that are subject to HIPAA for treatment, payment, healthcare operations, sometimes public health, for patients whose entities have in common. And when we kind of often hear that statement, we remember the first part and we remember that TPO aspect of it, but the second aspect oftentimes gets overlooked. And not only is that second aspect essential for HIPAA privacy rule compliance, but in addition, it really helps to support why ACRS is so important as an offering. And that's because it actually allows us to find who those patients are in common. So in our standard data sharing agreement and our kind of corresponding business associate agreements, we kind of collectively call those our legal chain of trust, and that kind of binds all of our organizations together in a uniform legal document. The HIPAA privacy rule is going to be one key component of that chain of trust, just because we're going to be attesting in that document that we're only sharing for treatment, payment, healthcare operations, sometimes public health under the privacy rule for the patients that entities have in common. And this is why ACRS is not only going to be important for us as a health information network, but it's going to be really important for the entities connected to us, because it's going to support their compliance with HIPAA and other kind of different federal interoperability rules that govern health information exchange. I have two more examples of other ways that ACRS can support compliance in the next two slides. I'll try and go through them fairly quickly, just so that Joanne can kind of get back to the who, the, and the why, and kind of wrap up that portion. But I think that these will kind of help to highlight how ACRS isn't just something that's necessary for us to help you. It's also going to be directly beneficial to your organization as well. So with that, we can go to the next slide and I can go through some of these examples. So another way ACRS supports compliance with federal interoperability rules and mandates is for the CMS conditions of participation for encounter notifications. And this is a mandate for hospitals to send admissions, discharge, and transfer or ADT messages to members of a patient's care team. And as you may have been able to call out when I was saying that, the important portion of that is really going to be that phrase, members of a patient's care team. And hospitals might not have a way of knowing who's going to be on a patient's care team unless, one, the patient's providing that comprehensive list to them, or two, they have a mechanism or framework in place to kind of determine who that team is. Luckily for us, ACRS does just that. It's able to kind of find that active care team of an individual, so hospitals know where those encounter notifications or ADTs are going to go. I'm not going to talk too much about future offerings or roadmap, but one thing that I will say is that eventually, we kind of help with compliance by helping to figure out who that care team is by provider declared relationships. But further on in the future, we might have additional functionality such as allowing patient declared active care relationships and so on and so forth. And that's just going to further support all the work that we're already doing in that space and helping with compliance for things like the CMS COPs. Next slide. And then my last example is going to be that ACRS really supports something called the Provider Access API. And this one may be just a little bit less familiar than the conditions of participation requirements, because this mandate was only just finalized about a month ago. But just as some background, in 2020, CMS released something called the Patient Access Rule, which required certain payers to make information available to the patients via open application program interfaces and the use of third-party mobile apps. This year, they finalized an expansion to that rule in which they asked payers to make that same information available to providers starting in 2027 through something called the Provider Access API. So while this seems really straightforward, one key component of this initiative is that CMS wants payers to confirm that they're only sharing information with providers who have a relationship with the patient. And CMS even goes one step further to urge payers to find frameworks for patient-provider attribution like our ACRS framework today. So even though this mandate's not in its compliance phase yet, that's not going to happen until 2027. The reason I listed this is because one, it's another example of ACRS kind of supporting a direct compliance requirement. But second, it shows that providers aren't going to be the only ones who may need to leverage ACRS for compliance. Payers will too. And that's just going to be another overarching point that I want to make, that ACRS is going to support all the healthcare actors falling under HIPAA through compliance with the HIPAA privacy rule. But in addition to that, there are going to be these kind of one-off mandates and initiatives that ACRS will also support either directly as it's a requirement, as we've seen in these two examples, or kind of indirectly by just helping that active care team really get established. So I did just want to touch on these two things so you could kind of understand how ACRS doesn't just help us as an org, but actually supports you as stakeholders to meet those compliance requirements. But I'll go ahead and I'll pass back to Joanne so she can delve a little bit more into that why.
Thank you. And just for the clarification, there's a question, is MiHIN regulated by CMS?
In a kind of indirect way. So typically the way that it works when it comes to compliance is for every initiative that there is, they actually name which actors are going to be subject to the rule. A lot of times health information networks and exchanges aren't going to be listed as a direct actor that is required to be compliant with certain CMS mandates and initiatives, but that doesn't mean that we're not compliant. The reason why we do tend to be compliant with some of those things, even though we're not a named actor, is because we're typically producing offerings that serve our stakeholders, and they are required to be compliant with certain CMS rules or different HHS agency rules in general. So with that being said, no, no is like kind of the straightforward answer, but the long answer is we try to ensure that everything that we're offering to you is compliant with some of those federal interoperability initiatives. I hope that makes sense.
Thanks, Shreya. Okay, so why ACRS? The Active Care Relationship Service is an interoperable technical service created to embrace a patient-centered holistic care model. It prompts better coordinated transitions of care by enabling physicians and care management teams to receive notifications when there are updates in a patient's status. The service was designed to improve post-discharge transitions, to prompt follow-up with patients, and to foster communication among providers to support patients, especially those that are moving between many healthcare settings, those with multiple or chronic conditions. Next slide, please. All right. Because we have ACRS as an underlying care mapping, we can very clearly point to a patient's care team at large. We can identify where they are and make sure there is a clear, concise, timely communication between those providers to more adequately care for that patient. So to boil it down, ACRS was designed to support a more personalized care journey. Next slide. The service is a care provider's claim that they are authorized to receive and/or query for their patient data the way that they want it. It creates the electronic roadmap between care team members, so any changes on a patient's status can be sent to those relevant providers, even if they are part of different organizations, even if they're working on different systems of record, even if they are in different sectors. Next slide. ACRS supports entities' ability, like local health departments, organ donor organizations, public health actors and agencies to take an active role within the healthcare ecosystem. Next slide. It helps payers streamline claims processing, reduce administrative costs by providing real-time access to patient data and supporting that authorization process. Next slide. And, ultimately, ACRS allows various, usually for-profit technology systems to communicate and to calculate and to innovate for their clients. Okay, so that was the why and for whom. Does anybody at this point have any questions or concerns? You with me? Great. Okay. So our primary uses of this service as it relates to our technology platform are to authorize access to protected health information, to discover who or where or what orgs may have documents or data about a patient, to route messages, and to expose the active care team. The sources of the information for this service come from participant attribution files, which we're going to get to. They're full patient rosters sent to MiHIN every month, which we use to update our patient-provider attribution map. And we can create a relationship in real time using messages that are sent to us for treatment, payment, or operations, such as ADT messages. As Shreya said, we use the active care relationship as a framework under the HIPAA privacy rule for treatment, payment, and operations to substantiate a relationship based on one of those three provisions. The MiHIN legal framework, as it relates to this service, specifies 4 different types of active care relationships. There are declared active care relationships, which come through these attribution files, which we are going to get to. There are assigned, which is when a third-party payer is attributing a patient to a provider. We have reported, which is when we use a message, like an ADT, and extract that message data. And there is derived, which is taking multiple data sources and analyzing and substantiating a healthcare operations relationship, let's just say, or treatment or payment. We have examples of derived, and I have my product manager here. So he'll get into that later if you guys want to dig into derived. Are we using HL7 CCDA standards? Yes, of course. And more here will be using FHIR. Next slide, please. Okay, so this is so how does it work, right? Okay, so we have many entities that are sending us patient data. When they send us that patient data, they are reporting that they have an active care relationship with this patient, which is why they are able to send us the data. At the same time, simultaneously, practices, provider organizations, payers, FQHCs, CMHs, all of the other care team members are declaring their active care relationships. MiHIN then, through its platform, finds and attributes these active care teams and checks their delivery preferences, and then is able to push or proactively send or make available for query the patient data to those active care relationships. Next slide. Haley, can we move?
Yeah.
No? Yes? No?
Hmm.
I mean, this is a good
Yeah,
slide.
I'm on the next slide.
Great. We got it. we're where we need to be. So I once asked, my team, like, what does this even look like? Like, so what? Who cares? And what does it look like, for goodness sakes? So this is kind of to show how ACRS has evolved. It's not just a patient-based roster that other exchanges in this nation have or use. It's not a phone book or an index. It's more like a Google search engine. We call it the patient-centered knowledge graph. And we've modeled into the patient-centered knowledge graph real-world objects like patient, providers, organization, even abstract concepts like zip codes, dates, risk scores, more and more social needs, and many others. And we can pull from data exchanged attributes like diagnosis or encounters or population health related attributes like date of birth, again, zip codes, or whatever may be defined of interest. We can also map, Mick, I think this is you. I love you in the chat. We can also map patient choices like active care instructions, active care, advanced care instructions, advanced care documents, and consent into this graph to make it discoverable. Essentially, what we've built is a map where if you tell us what you're interested in for a certain population, let's say, we can connect you with patient identities that match your description, provided only that you are authorized to see this information. Dawn, let's get to your question at the end of this. I'm going to have, Shreya, are you sticking around till the end?
Yes, I am.
Okay, great. We're going to talk about consent to share at the end, if you don't mind. All right. Next slide, please. So each patient's active care relationships are continually verified in several different ways, and we're going to get into it. But essentially, we have these things called attribution and delivery files, which are submitted to MiHIN for validation. MiHIN validates the ACRS and attribution files and provides feedback to make sure that these files can be validated. Basically, we need you to get it into the most perfect format. It is simple, but it's not easy, and I'm going to show you. Then we confirm the delivery preferences for the patient's care team, and we route the data to the receiving organizations via those delivery preferences. Next slide, please. All right. So how can you participate in ACRS? Organizations that can capture their full list of patients that they have a relationship can submit the full file on a regular basis. Flat file submissions via secure file transfer protocol allow for immediate removal of an inactive relationship instead of waiting for the 90-day automatic expiration. So basically, there is a connectivity form, right, that you are sent from our customer engagement specialist. And we basically teach you how to create these files, this attribution file and this delivery file. And then you have to put them in an input folder. We validate them and we put them in an output folder. If a patient appears on the list 1 month and it doesn't appear on your ACRS file the next month, that patient is no longer considered to be a participating patient for you. They are no longer on your active care relationships roster. So every month is a full refresh of the month before. Now, you can also use My Gateway. And if you guys want to learn more about My Gateway, come back next week, come back next month. You can also use My Gateway to submit these files. Again, Um, every file is every submission is a refresh of the previous. You can also use ADTs that you send to MiHIN as the basis of a 90-day relationship. Let's see. Care team members. Okay, let's just keep this here for a second. So you can submit a flat file via SFTP. You can upload that flat file through My Gateway, or you can use the ADT messages that you send to MiHIN to create the reported active care relationships for your organization. Next slide. Should note also that care team members that utilize My Gateway can use this web-based portal to add, edit, and remove relationships on the fly. But you go one by one. Okay. For providers and care coordinators, an active care relationship means that a provider has seen the patient within the past 24 months and expects to see them again. Now, I want to take a pause for a second. If that's not how you want to define your active care relationships, if you don't want it to go, 24 months back, you don't have to. You can define who you want your patient population to be in terms of what data you want to receive from MiHIN. For payers or care managers, an active care relationship is attributed to an eligible member of one of the payer's health insurance plans. So in your ACRS attribution file, this is for all patients who the healthcare professional and or organization is attesting that they have a legal relationship with. The delivery file is how. How are we sending you this information? What is your preference for how we send this to you? Attribution and delivery files are submitted to MiHIN every month for accuracy. Again, files are a total refresh from the previous month's submission. It is up to you to make sure you know and who you are attesting is a part of your active care relationships. It should also be noted that if you make a bunch of attributions, but define no delivery preferences, you won't receive the data in a directed way. You may still be able to access that data through My Gateway to see your patient population, but we wouldn't know where to actually push the data to you. And also, please be advised that if you will not receive messages for any records in an attribution file without a corresponding provider row in the delivery file, they have to match. Who, how. Okay, now we're getting into it. So ACRS has a specification. You have to meet the specs for this service. And there are two different types of specifications. There is the PO ACRS file spec to be used by provider organization type entities, whereby a patient is related to a provider, a practice, and or a managing organization. Non-PO ACRS file specs are to be used by entities who are not provider organizations, whereby a patient may only be attributed to a managing organization. Non-POs could include payers, care management organizations, or others that would not necessarily be able to specify relationships on the patient to provider and practice level. Next slide, please. Oh boy. Okay, we're here. So like, what do I have to do, right? So what? Who cares? if you are here and you need to be working with us through our migration, if you want access to my gateway, and if you want to participate in data exchange, you will participate in ACRS. And so you'll send us an attribution file and a delivery file. So here's what our spec looks like for an ACRS attribution file. You'll see that you have to list a patient, your patient ID, another patient ID, first name, middle name, last name, date of birth, gender, last four of the social, their address, and then the attributing physician's NPI, the attributing physician's first name, last name, attributed practice OID, unit name, managing organization OID. Next slide, please. On the delivery file, you will have NPIs, a provider NPI, that provider's first name, last name, specialty, direct address, a practice OID, the practice type, the name, address, the city, the state, every time, the organizational OID. And of course, your delivery preferences. So when I saw this, I was kind of cross-eyed, and I was like, all right, so like, how do I build this thing? If I need to get it to you, like, what does it actually look like? Next slide, please. So this is an example of what the attribution and delivery files look like. So Kaylee, I'm going to kind of ask you to like move back and forth between this and this one and the one before, two before. But basically what you'll see, so go to two before on the attribution file if you could. Attribution. All right. So we see field number 1, unique patient ID. Field number 2, secondary client ID. Number 3, patient first name. Okay, now go back to our sunny side, please. Go back to that other, and here you see in column 1, unique patient ID. In column 2, secondary client ID. And number 3, patient first name. So our spec tells what your headers will be and what information needs to follow in the rows that, that come beneath it. Next slide, please. Okay. I'm leaving lots of time. I think I'm good on time because I think we're going to have really, really good conversation here. But so again, these specs, right? You're coding essentially, and it's simple because there are rules, but it's not easy because you are humans. Sometimes your EMR or EHI or your system of record can, can build these files for you. And sometimes you might be in an organ donor, organization, and you just need to submit those flat files by yourself. Okay, so a couple of tips and tricks. These attribution and delivery files, and remember, there has to be an attribution and a delivery, and they need to both go in the input. And we go over all of this on your onboarding, so no worries. They have to be saved in a CSV format, okay? All of the headers, you really have to pay close attention to the headers. Each header in the file, review each header in the file to the data element values in the ACRS file specs, right? So everything that we say we need in that first column needs to be in that first column. Um, there are file naming conventions that we go through with you when you onboard. Those will always be your naming conventions. And some of the stuff that gets us caught up in these validations is really just human stuff. There are sometimes we encounter issues like a typo where someone types patient instead of patient, like it's going to fail. SSN last four instead of SSN dash last four. We want the dash. We want the space between the dash. We need it to be an exact match. If you transpose one of the headers where you have a managing organization state in the column before the manage organization zip, it's not going to work. Okay. Now, let's see where we are. Next slide, please. I think we've made it through the why, the who, the how, and the what. I am really interested in what's going on with the chat. I'd love to hear from all of you. We do have, as promised, the technical people, these people that make these files perfect for you, these people that are building this patient knowledge graph. And now is your time to ask those questions and really gain access to them. I'm seeing lots of stuff in the chat. Does anybody want to come offline and tell me what we're learning here? Anybody want to give a summary? Any questions, any concerns? Talk to me, please.
Hey, Joanne, this is Matt. Not sure if you were asking us, but just reading the chat as you were talking, it looks like there's a lot of questions around uploading files, which you kind of hit at the end. And then there's some questions around where we are on risk scores in terms of timeline and implementation. And I'm sure there's some other stuff in there, but that seemed to be like the stuff that had the most activity.
Okay. Right. So it seems like there's like questions about the logistics.
Right.
Of like how these files, how these files get validated, what people have to do to make sure they're not making mistakes, where they put them.
An error, almost getting an error uploading to my gateway. Is anyone else having that? That kind of thing.
Right. I don't think one of the hardest thing about this is that each of your journeys are going to look different and they take hand holding. So it's once you've got it, but getting you there is the work. And we do have the most dedicated help desk and system analysts and customer engagement folks working for us, working their butts off to make sure that we continue to be able to be a nonprofit, continue to be able to work between different very powerful sectors, and really working to make it so that we make this as easy for you as possible. I'm seeing some, the risk scores. We received an ACRS audit notification, but do not understand what it's trying to tell us. Okay, so I'm coming out also. I will be putting this together, a sort of like, you got this message, now what? An ACRS sort of like vocabulary, Chris. So I'm really hoping to get that out. I'd like to be able to send it with these slides and then post to our website. I'm seeing some conversation.
Hey, Joanne.
Yeah.
It's McTally.
Oh, yes. What's up?
First of all, we wrote a consent document years ago, and it went through the legislature and was signed by the governor. So for those who want to know legal reasons, it's available. What we've been waiting for and talking about in your model is the consent process is primarily paper. The patient has to go to the office and, sign the document, blah, 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 blah. Okay. Well, I don't know about a lot of the lives of the people on this call, but some people get really busy and taking time out of their day to go sign a document. Some people are not going to like that. So at AHIMA, we wrote a profile on how to do this electronically. So as I look at the model, is there the view that we'd like to digitize some of these processes so we can automate them and have them move faster?
Yeah, I mean, I'm not your perfect person here, but I know that MiHIN's been working on our electronic consent management
Oh, good.
service. I put in a link to that on the from our website. And if you want to dig in, Mick, I know there's a lot of nerds that would, people,
I'm a nerd. I'm a
yes, yes,
geek.
yes.
It's
I know there
okay.
are
I
a
will
lot of
dig into
people
that.
who would love to dig into that with you. I will
Okay.
say that so consent to share, right? Consent to share versus specific consent about specific information like CFR Part 2 or other things. It looks like it's going back and forth in the chat, and if patients don't want their information shared, the information should not be sent to the health information exchange. Period.
Is that drug and mental health and all of that restrictions still applying?
That we have, you'll see in our ECMS that's what we have solved for first.
Okay.
The CFR Part 2 consent, yes.
Yeah,
Okay.
Joanne.
And, oh, go ahead.
Oh, I
Go.
was just going to say, yeah, Joanne, our ECMS solution is specifically for 42 CFR Part 2, but because in Michigan specifically, our mental health code allows for information to be shared for treatment, payment, and care coordination without consent. That would also be one that, similar to what you were explaining to Mick, would need to happen at the data senders organization. If they go to the provider and say, we don't want any of our information sent to outside of this organization or to the health information exchange, then they would be required to honor that. And that just would be the information that's not coming to us. But everything else could. And I know there was like a question on if you can send information from other patients who might not have opted out at the sending organization, all of that's still allowed. It's just going to be some of those explicit restrictions on sharing information without consent that our e-consent solution will accommodate. And Mick, I will say, I do think eventually we want to do something really similar to what AHIMA has kind of outlined and get it to that place where it can be automated. So it's definitely in the works, just not entirely at the automated stage yet.
Thank you, Sharia. I worked on that document. That's why I know about it. Okay.
I remember. Yeah, I do remember.
You remember? Okay.
And Mick, this is Matt. Just
Hey.
adding on to Shreya's comments, the ECMS solution. I'm not the ECMS product owner, but Van Lee is. They do it digitally, but it's mediated through the provider. So it's I haven't read the document you're talking about, but I expect you're talking about a patient-facing consent experience, and it's not that yet. But not to put words in Van's mouth, I'm pretty sure that's probably where he would want it to go. And then how it connects to ACRS is once we do capture that consent digitally through the provider office, then it gets stored as an attribute on the patient in ACRS, and you can do queries for active care team with consent. So it becomes digitized at that point, but I think you still got to be at a provider office to do it.
That's not good.
No,
When
yeah,
we
I get it. It's a gap.
when we did that AHIMA report, I quoted my girlfriend who I asked about it, and she said, "I'm busy and I don't have time to go by my doctor's office all the time. So I want to be able to do that digitally because if I have to come in, the doctors are going to figure out some way to charge me." And so it was mostly women. They all laughed like Sharia, but we wrote it into the profile. So some people want, we're moving into a more digital economy. And when you talk about, sending data to the payer, well, the payer has a bank, and there are efforts within financial institutions to do something called faster payments so that providers can get paid faster. I have a colleague named Kendra Wyatt who runs a birthing center in Kansas City. She's very deep in the weeds on this stuff. And Kendra said in another venue, why do I have to wait 30, 60, 90 days to get paid? I got to meet a payroll. So I think, ACRS might lead to, if we do it right, a way that providers can get paid faster.
Thanks, Mick. I mean, yes, let's do that. 100%. Let's also make sure that everybody here is getting what they need from this time. I'm still looking through the chat. I'm seeing some questions yeah.
Sorry, Joanne, I'm going to chime in real quick
Do
because I
it.
would love to hear more from Sarah Wild. So
Yes,
she put a
right.
question in the chat and said, is ACRS the backbone for the Blue Cross Blue Shield pay for performance and post-acute SNF provider network? I would just love to hear more about what it is that you're asking, because I think like that conversation can go so many different directions, but I want to make sure we answer your question.
Thanks, Megan. This is Sarah. The reason I asked the question is we've been notified by both of these networks, both by Blue Cross and Michigan Medicine specifically, that because we are not providing our ADT notifications directly to MiHIN, that we are at risk for payment reduction. And it actually comes into another conversation that we are submitting our ADT information directly to the Care Quality Commonwealth program infrastructure. And there's communications now that they potentially are going to be submitting this information to MiHIN. So I was just hoping to get some clarification on that.
Hey, Megan, this is Brad at Blue Cross. Can I chime in real quick?
Of course. So happy to see you're here.
Hey, I just want to clarify something that Sarah said. I don't want the audience to hear what she said and misconstrue. If a skilled nursing facility does not send ADTs to MiHIN, there is no reduction in your reimbursement. You will receive full reimbursement if you do not send ADTs to MiHIN. If you do send ADTs to MiHIN, and there is documentation of that, and Blue Cross finds out about that in our checks that we do every 6 months, you'll receive additional reimbursement. So there is a reimbursement above the 100%. If you do, if you don't, it's completely optional. It's totally fine. You'll still get full reimbursement. Just want to clarify that.
Yeah, Brad, you're correct. I apologize. We have been receiving the 4%. But okay, now they're coming back and saying that they're not receiving our ADTs specifically to MiHIN. So they're going to take that back.
Right.
But our ADT messages are going out to Care Quality and Commonwealth.
You sent, Sarah, there's probably a lot of the patient's care team members that would love to see the data that you have. Is there, can you just send it to us?
When you say the data that I have,
like, so your ADTs, can you send your ADTs to MiHIN?
No, the software is sending it directly our EMR is sending it directly to care quality. So I never touch that per se.
I see. Yeah, we work with about 110 different EMRs. If you want to side, if you want to take this offline, I bet we can connect with your EMR. It's our job.
Yeah,
Yeah,
typically, Sarah, you, a skilled nursing facility rarely will be the entity that directly sends the ADTs to MiHIN. So you may want to contact care quality and just say, hey, our ADTs are funneling up to you. We need you to connect with MiHIN and make sure MiHIN gets those. And MiHIN understands that those are coming from XYZ facility or whatever the name of your facility is.
Yeah, and that's the level that I'm at right now.
Okay, cool.
But Joanne, I'm more than happy to take this offline.
Yeah, let us know who you're working with. I mean, I personally bother people all day long. And I am happy to bother your provider, your vendor, and say, if you can send these messages to that endpoint, we believe strongly that we can make it super easy for you to send it to this endpoint.
Perfect. Thank you.
And when they do that, that means that everybody else caring for that patient will be able to see that information, which is not happening through the other exchange.
It's very interesting though, because we're receiving results through that exchange from our local providers. Like I'm getting CCD files, I'm getting their
from the
ADT
people that
messages.
participate in that exchange.
Correct.
Right.
Yeah, that I think is key, is that you have some organizations that do participate in Commonwealth and some don't, right? So by sending data to the MiHIN network, we are able to route that data outbound based on these active care relationships to the members of that patient's care team. And in the stance that they're not connected to Commonwealth, they're still going to get that data. But even if they are connected to Commonwealth, maybe they get some data that they don't get from Commonwealth, or it's just, more data, whatever it may be. But the key thing in just remembering too, like when you're sending to those outbound exchanges, is that even if you are sending or getting data back, not everyone's connected to that entity like Commonwealth.
Joanne, this is Julie. I don't have anything to add to that, but it sounded like we didn't have any additional comments on that. I just had a couple things I wanted to add to people operationally that are thinking about joining the ACRS service.
Sure. Julie doesn't work for MiHIN. I guess I should probably say that.
Yeah.
but what would you like to surface?
Keep in mind if you're thinking about doing the ACRS service, and then moving on to additional use cases and sharing that data, is to make sure that your patients that are involved are not surprised by the fact that you're sharing their data. One of the ways we did that is to make sure that consent, as well as the information that we're sharing that data, goes into that paperwork that they sign when they show up to the front desk, as well as the front desk staff explaining that to the patients, especially if they are elderly patients that really don't understand the ability to share information electronically. So just keep that in mind. And the other piece was that we talked about different ways of sharing the ACRS files, the attribution, to be either through the ADTs or through the files or through My Gateway. One thing that was noted on the slide was that the ADT process looks back 90 days. So if you're a practice that is a PCP, you probably haven't seen that patient in the last 90 days or so. So you want to make that attribution file include whatever your process is to identify your patient population, whether that's the last 2 years, 3 years, or whatever that is. to
It
make
can't
sure
go
that you're
past
getting the
24
information.
months. Yeah.
Yeah, you're right. And everybody's different. So I mean, it could be 1 year, could be 2 years, could be, 2 encounters, 5 encounters, whatever your process is, to keep that in mind, if you're looking at the different options. That's all I had to add.
Thanks, Julie. I think that was really helpful.
Joanne,
We
I see
have,
there's a question in the chat from Amy Robertson.
yeah, she's asking, how does MiHIN respect the patient preference of sharing and not sharing from a sending source if we are able to remove a provider relationship in the event? But I thought that we had been through this. MiHIN has a derived relationship. Don't send us the data if the patient doesn't want it to be shared. We exist to share patient information.
Yeah, Joanne, I was in the process of typing a response to that question, but I was going to say the same thing, that the expectation is that the healthcare provider not send the message when the patient conveys that to them or makes a relationship change. But I just want to make sure I understand the first part of the question. So if there's anything that we might have missed, please feel free to clarify.
Luckily, we meet with Amy often, so we can continue to dig in. Are you able to include discharge papers with the ADT feed? Julie's asking this question.
Discharge summaries are a form of data that we can send outbound to organizations that are interested in receiving them. So there's a couple of different options where MiHIN has a use case scenario for discharge medication reconciliation, and those are those discharge summaries or those consolidated continuity of care documents that come from the hospitals, and those hospitals send to MiHIN and we disseminate outbound. We also have a different use case scenario for ambulatory CCDA exchange. So there's a couple of different things that we can do there too, based on kind of what it is that you're wanting to do for your organization. But I'd also like to add that within the MyGateway TOC viewer module, MiHIN does and can send ADTs and CCDs to that TOC viewer, but we also make it easy for the users for the TOC viewer that MiHIN will sync an AO3 with an accompanying CCD if there are patient matches and the encounter ID matches the ADT and the CCD as well. So a couple different options there. Julie, I can put my email address in the chat if you want to talk about that one further as well.
We had a lot of good engagement on this, and I really want to thank everybody for coming. I'm also putting my email address in the chat. We're here for you. I got to give a thank you to all of my associates who have joined me here. We really want to share our why with you, why we feel proud of this patient-centric sharing model. Hannah, you have 1 minute left. Anything that you want to, any last comments you want to say about ACRS submissions or validations? A parting word. Okay. Thank you, everybody, for coming. We have Shreya, we have Megan. Thanks, Megan, and me, Joanne, and just keep coming back. Next month, it'll probably be about MyGateway, which has that TOC viewer that Megan was talking about. It also will house our longitudinal record moving forward, and it is where you can access your patient data if you don't want it sent directly to your EMR. Thank
Joanne,
you very much. Yep.
Sorry, I was trying to get Phil's question answered. So maybe I'll connect with Megan after the call and we'll get back to him too.
I see this back and forth. Okay. Attached to a PDF testing results.
And I think the question is, can we route a PDF with drug results if they sent it to us? Megan, is that a question we can get back to Phil on?
Yeah, we can.
Okay.
Yeah, Joanne, if you will probably just have to get Phil's email address from you, unless Phil, you can put it in the chat real quick.
And we'll follow up with Julie.
Awesome, thank you.
Thanks, everyone. Forensic fluids. Interesting. Thanks a lot. Have a
Thanks,
wonderful
Joanne.
day.